Our today's topic is cleft lip and palate. Embryologically, the area of lip and palate it is divided into primary palate and secondary palate. So what does the primary palate constitute? The primary palate includes the central portion of the upper lip and the alveolus bearing four incisors. So these four incisors and the palate that is anterior to the incisive foramen is the primary palate. Now how does this primary palate develops? The primary palate it develops from the median nasal process and it fuses with the maxillary process. The median nasal process and the maxillary process they get fused between the 4th and the 7th week of intrauterine life to form the primary palate. What does secondary palate includes? The secondary palate includes the palate that is behind the incisive foramen. So how does it develop? It develops by positional change. So there is a change in the position of the palatal shells of the maxillary process from the vertical to the horizontal position, and they then fuse from the incisive foramen progressing toward the uvula. So this fusion takes place between 7 to 12 weeks of the intrauterine life. Now let us discuss the development of the cleft lip. Now how does the cleft lip develops? The cleft lip it develops due to the failure of fusion between the median nasal process and the maxillary process. So the median nasal process and the maxillary process fail to fuse together. At the 7th week of the intrauterine life, the palatal shelf from the maxillary process they lie vertically on either side of the tongue, and on the 8th to 9th weeks the tongue will drop down due to the extension of the head. So the palatal shelf it will sink into from the vertical position it will sink into the horizontal plane. So by 12th week, a complete fusion of the palatal shelf in the midline take place. So this alteration of the palatal shelf force may cause cleft palate. In Robin syndrome, what you will see, there will be failure of tongue to drop down. So that would lead to cleft palate. Or there could be non-fusion of the cell of these shelves. Now, what is the etiology or the factors that are responsible for development of the cleft lip and palate? They could be genetic, environmental factors or gene-environmental interaction. The cleft lip associated with the cleft palate it is more common in the male, whereas the cleft palate alone it is more common in the females. In condition like van der Waals syndrome, where the lip pits they are associated with the cleft lip and palate, so they give rise to autosomal recessive type of inheritance. The environmental factors like rubella, exposure to drugs, trauma, complication of pregnancy can lead to development of various type of defects. So various drugs like the thalidomide and anti-epileptic drug can cause cleft palate. Now what are the syndromes that are associated with the cleft lip? It can be associated with many syndromes like Down syndrome, Waardenburg syndrome, where there is abnormality of pigmentation of hair, iris or skin and deafness. The Van der Waals syndrome associated with the lip pits, orofacial digital syndrome. There is median cleft lip that is associated with bilateral accessory toes, Trachean-Collins syndrome, where there is hypoplastic zygoma, micrognathia, external and middle ear defects, Pierre-Robin syndrome, where there is micrognathia, glossotosis and respiratory obstruction, or Klippel-Feil syndrome. Now let us discuss the various classification of cleft lip and the palate. Number one is the Davis and Ritchie classification. Based on that, it can be group 1 that involves the cleft of the soft palate only. Group 2 involves the cleft of hard and soft palate till the incisive foramen. The group 3 is the unilateral cleft of soft palate, hard palate, alveolar ridge and lip on one side, and on the both side is the group 4. The other classification is Carnahan classification. Carnahan proposed the strip-wise classification. So the number 1 and the 5 refers to the nasal floor. 2 and 6 represents the lips. 3 and 7 represents the alveolus. 4 and 8 the hard palate anterior to the incisive foramen. The 9 and 10 hard palate posterior to the incisive foramen, and number 11 represents the soft palate. A simple Indian classification is the Nagpur classification. It was first described by Professor Balakrishna, an Indian plastic surgeon, that consists of group 1, that is cleft lip only. Group 1A involves the cleft lip alveolus. Group 1B involves the subsurface cleft lip. Group 2 involves the cleft palate, and the group 3 involving the cleft lip as well as the cleft palate. The cleft palate may be unilateral or bilateral. It can be either complete or incomplete. The complete that extends from alveolar ridge to the uvula. The incomplete involves the secondary palate only, whereas the complete involves the primary and the secondary palate. The example of incomplete is the bifid uvula or submucosal cleft palate. So the condition in which the roof of the palate does not form properly. So this cleft is opening beneath the mucous membrane, the tissue that covers the palate. So typically this type of cleft is seen when the baby is born. View classification. Class 1 unilateral notching of the vermilion border and not extending into the lip. Class 2 unilateral extending into the lip but not including the floor of nose. Class 3 is unilateral extending into the floor of nose, and class 4 is bilateral cleft of lip whether incomplete or complete. Other is the Fogg-Anderson classification. It can be number 1 hair lip with cleft palate, or isolated cleft palate, or atypical clefts like median cleft lip. So what are the problems that are associated with the cleft lip and the palate? There could be dental problems, skeletal problems, nasal problems, feeding problems, earway problems, speech problems. So first are the dental problems. What are the dental problems? There could be tooth defect in the cleft lip and palate children. There could be supernumerary tooth, congenital missing teeth, peg-shaped teeth, gemination, fused supernumerary teeth. All these are feature of the cleft lip and palate. Delayed eruption pattern of the permanent teeth may be present. Enamel defect can also be present in deciduous cuspid molars and first premolars and the first permanent molars. The skeletal problems are the maxillary deficiency, mandibular prognathism. They have a class 3 malocclusion with concave profile. The babies with the cleft palate will have the feeding problems because the roof of mouth it is not formed completely. So patients with the cleft abnormalities will have trouble creating enough suction to pull the milk from the standard bottle. So the babies with the cleft palate need to be fed with a specialty bottle system, so that provides the proper nutrition without the need for the pressure while sucking. Now what are the ways to manage the cleft patients? Number 1 is in the case of the cleft palate, we can give is the stage 1 treatment that includes the fabrication of the passive obturator. Second is the pre-surgical orthopedics. Third, surgical management of the cleft lip and the palate can be done. What is a obturator? So obturator is a disc or plate that closes an opening or defect of the maxilla as result of the partial or total removal of the maxilla. So obturator, it is an intraoral prosthetic device. It fills the palatal cleft. So it will give a false roofing against which the child can suck. So it reduces the feeding difficulty like insufficient suction and excessive air intake. So the obturator, it can be fabricated using cold cure acrylic. What is nasoalveolar molding? The nasoalveolar molding creates a good functioning palate. It normalizes the tongue position, helps in the speech development and improves the symmetry of nose and the cleft of the maxilla. So this is nasoalveolar molding. There was an image that was asked in your entrance exam. Identify this. The answer is nasoalveolar molding. So it is a non-surgical method of reshaping the gums, lips and nostril with plastic plate before the cleft lip and palate surgery. It reduces the gap in the upper lip. It lifts and narrows the nose. So remember, it acts as a adjunct procedure to enhance the aesthetic and functional outcome of the surgical procedure, as it reshapes the nasal cartilage and mold the maxillary dentoalveolar arch before the surgical cleft repair. So the main goal of the nasoalveolar molding, it is to correct the malpositioned nasal cartilage and normalize the position of philtrum and columella. So that will decrease the tension on the incision line and also decrease the amount of surgical dissection. So there is always a debate about the timing of surgery. So for the cleft lip repair, the most of the surgeon they follow is the Millard rule of 10. That is, weight over 10 pound, hemoglobin over 10 grams and age over 10 weeks is the best time for the cleft lip repair. So what are the various techniques that are used for unilateral and bilateral lip repair? So remember these techniques. The techniques that are used for unilateral lip repair are Millard's, Jenkinson, Rendall, Tillier's method, and for the bilateral lip repair are the Millard's, Cook, Mulligan and Manchester techniques. The Millard rotational advancement flap. It is also known the Millard rotation advancement flap. It is also known as rotational advancement technique. The advantages of Millard technique it preserves the cupid bow. So it will preserve this. This is the cupid bow and the philtral dimple. The scar will be placed in anatomically correct position along the philtral column. So in the Millard rotational flap, you will mark the points on the cupid bow. So these are the points on the cupid bow. So these show the incision line, the A, B and this one is the C. So the incision is made that mobilize the flap to allow its advancement into the rotation gap. So the closure, it is started by elevating the nostril. So the importance is that it provides extra length to the short column and also reduces the defect at the back cut. The disadvantage of the Miller technique is that the vertical scars that occupies the filtral column can subject to wound contracture that can cause shortening of the lip on the cleft side. For the bilateral cleft repair, remember the flap C is never allowed to cross the midline of the columella. This is to preserve the blood supply to the columella. The other is the Pfeiffer incision for the unilateral cleft lip. So here you can see is the placement of dots S-shaped marking on the both side of the lips. The final incision line should follow the lateral line of the philtrum. It is a tension-free closure of the cleft tissue. It can be done even in the case with the wide clefts. There is adequate lip length and follow the symmetry of the philtrum and the cupid bow. The disadvantage is the final closure is over the philtrum. Other technique is the Afros incision. It is combination of Millard incision, that is on the non-cleft side, and Pfeiffer incision on the cleft side. The Millard incision on the non-cleft side would aid in the rotation, while the Pfeiffer incision on the cleft side that would help in the lengthening of the lip. So while repairing the bilateral cleft lip, following principle should be always kept in mind. You should maintain the symmetry of lip. The blood supply should not be compromised. Create the continuity of the orbicularis muscle. Reconstruct the buccal sulcus with the prolabial mucosal flap. Anatomical placement of lateral cartilage and preserve and elongate the columella. Now what are the techniques we use for the cleft palate repair? The techniques are von Langer-Beck technique. So remember, von Langer-Beck technique is technique for the cleft palate repair. Bardak 2 flap technique, Furlow technique, Deleuze technique, Sommerland technique. The cleft palate, it can be repaired in 2 stages. The first stage, that is the soft palate repair before the 18 months, followed by obturation of hard palate. And second stage is the hard palate repair, that is done at 4 to 5 years. So what are the techniques? The techniques we can use is Langer-Beck operation. So here the relax incision, they are made behind the alveolar ridge that will create bipedical flap for the midline closure. So care has been taken to preserve the greater palatine vessels. And finally closure of the nasal mucosa and muscle repair is done. There is VY pushback technique. Here the design of it is a design of W incision. What you do is elevate the bilateral mucoperiosteal flap, taking care of the palatine vessels. The levator velli palatini muscles, they are freed from the posterior border of the hard palate. The muscles, they are repaired across the midline of the soft palate, and the closure, Y closure, is done. That is why it is known as VY pushback palatoplasty. So the Y closure will create additional length but also leave large raw area bilaterally. The children with repaired cleft palate may have resulting condition that is known as valvopharyngeal Incompetency. That means too much air escape through the nose during the speech, resulting in nasal speech. So that occurs because the repaired soft palate is too short and it does not move adequately. In this operation, some of the tissue from the palate and back of the throat they are repositioned to help close off the escape of air through the nose. So this figure is important as it represents the modality in the management of the cleft based upon the age. So at the 16 week of pregnancy, what you will see is you will diagnose the cleft lip by the ultrasound images. At the prenatal age, you can discussion with craniofacial. At the neonatal or immediately after the birth, you can do the pediatric counseling, give feeding instruction. Within first few weeks of life, you can do hearing test. At 0 to 3 months, you can do is pre-surgical orthopedics that involves the nasoalveolar molding. At 10 to 12 weeks is the primary surgical repair of the lip. Before the age of 6 to 12, before the age of 6 to 12 months, you can do is primary surgical repair of the lip. Before age 6 to 12 months, evaluation of surgical repair of cleft palate. At 3 months after palatal repair, you can evaluate for speech and language assessment. The 6 to 12 year is for secondary alveolar bone grafting. Remember that is important for your entrance exam. The secondary alveolar bone grafting is done at 6 to 12 years of age. Orthodontic treatment at 10 to 14 years, and orthognathic surgery that is performed after the age of 15 years after the growth cessation. So orthognathic surgery is performed after the growth cessation. The alveolar bone grafting, it is integral part of the correcting dental arch interruption in patient with the cleft palate. So the goal is to establish the continuity of the dental arch. So this one is the classification for alveolar bone grafting. Primary is done up to 2 years. Early secondary is done at 2 to 5 years, and secondary is done at 6 to 12 years. Early mixed 6 to 8 years, and late mixed at 9 to 12 years. So there is minimal maxillary growth after the age 6 to 7 years, and the effect to the grafting at this time bit results in minimum to no alteration of the facial growth. The secondary bone grafting, it is done before the eruption of the permanent canine, usually when the 1/3 to 2/3 of the canine is formed. It is done between the age of 6 to 12 years. Two types, early and late. The early bone grafting is done before the eruption of lateral incisor, and the late secondary bone grafting is done after the eruption of the permanent canine. Now, what are the types of bone that we can use is autogenous bone or allogenic bone. The autogenous bone can include iliac crust, which is the most common used, cortical bone, bone duct, or the blocks, whereas the corticocancellous sites are the iliac, rib, tibia, mandible. Which one is the gold standard of the donor site? It is the iliac crust because of the accessibility and quantity of the bone available. So patients, they are encouraged to mobilize on second post operative day. Soft diet is advised for a month.